Hello, I'm Vanessa Jacoby. I'm a professor of obstetrics, gynecology, and reproductive sciences, and I'm the Associate Vice Chancellor for Clinical Research here at UCSF and the Director of the CTSI. I'm so excited to have this opportunity to interview Dr. Natalie Wilson. Dr. Wilson is an Assistant Professor of Nursing in the Department of Community Health Systems at the UCSF School of Nursing. Dr. Wilson has over 30 years of clinical expertise in primary care, HIV, and sexual health. Her current research focus is on ending the HIV epidemic by developing innovative solutions to address constraints in accessing HIV prevention and treatment in health for marginalized populations and those in disadvantaged socioeconomic environments. Dr. Wilson uses mixed methods, implementation science methods to transform healthcare by building in health equity at the individual, system, and community levels. I have gotten to know Dr. Wilson a bit through our CTSI K Scholars program, and I'm so delighted that you agreed to speak with us today and share a little bit about your work.
Yes, thank you.
Natalie, let's just start. Can you tell me a little bit about yourself and what brought you to your current focus on HIV prevention?
Well, that's a long story, but yes. I could say that I started my healthcare journey as a candy striper volunteer at a Black hospital in Nashville, Tennessee. That's where I grew up. And that hospital is now known as Meharry Hospital. And that was literally my summer camp as a teenager until I was old enough to work for money. So our parents would just drop us off on their way to work, and we would literally volunteer at the hospital all day long. And they fed us. So we could have breakfast and we could have lunch and sometimes even dinner if we stayed long enough. But that, I think, is where I learned how to care for people and to get to know people, not just, they're in the hospital, but actually get to know them in their lives. And understand what kind of constraints they had when they left the hospital, because this was all through conversation, seeing who came to visit them or if they didn't have people coming to visit them. But I also grew up in the community, and I had a single mom that worked 2 and 3 jobs. So we were poor and we had constraints ourselves. And when I became a nurse practitioner in the late 1900s, I actually ended up running a homeless clinic. And that is where I just learned how to get innovative in caring for people because the resources were so low. And, I went to I used to do mission trips, and for many years I saw a group doing work with people living with AIDS in Africa. And one trip I just decided, this is what I want to do. I want to support people in the quality of life they have, and what they're dealing with. And it was in that mission trip in 2001 that I said, I want to go into HIV and I want to support them in primary care. And I was asked to come back, get some experience only in HIV. And then that happened almost immediately. And I found a job in HIV. I first was in private practice and I realized I didn't like it. I was meant for the community. And that's why, I started working with people that were living in the margins. And I brought all those experiences from my past to now to support people in having a quality of life and being able to access health and care in partnership with providers.
Thanks so much for sharing more about your background and how it's connected to your career. One of the things that I know you've highlighted that's unique about your work is how you use implementation science methods to really advance your mission-driven work. Tell me a little bit about that methods approach and how you think about that in terms of HIV prevention for underserved communities.
Yeah, so there are interventions that we know that work. We know the interventions work. They've been in a study, they've been in a nice little vacuum package, and we know that they're effective. However, when you look at the outcomes, you know that for some people that are marginalized or living in the margins that can't access the care or access the interventions, these interventions actually do not work. And so with implementation science, you can actually look at the effectiveness within the context of the population of the human being, what they are dealing with. And we use an equity focused consolidated framework for implementation research, or the CFIR. And this allows us to look at various domains of implementing an intervention and the strategy that you use for that. So our normal healthcare system is really set in a structure of capitalism. It's an economic system that's based on private ownership of an enterprise that is based on producing and operating services for a profit. And that's our system. That's our structure for providing healthcare. So the better we are at producing health within that structure, the more the organization is rewarded. And so efficiency and meeting indicators is just great. But the cost of that is that some people are not able to access that healthcare. So it's not efficient for them. It's not easy for them to achieve the measure of health that we're looking for. And so that person is just kind of skirted out. And we may not even know that those people are even existing out there. We just know what our numbers are, and we know that we're not achieving our outcomes or in the national strategy for something. So you take a person, just as an example, that's say homeless, which that's the population that I'm now funded to work with. Like, you can make an appointment, a 15-minute appointment for that person, and it's at 2:00. You can even give them 30 minutes. Because you got to spend more time, which doesn't really happen that much. But you give them 10, 15 minutes, and you make an appointment for 15 minutes at 2:00 on Wednesday, March 15th. One, that person has to be able to know what day it is, what date it is, what time it is, and then work out the way to get there. And even if it's like telehealth, how are they going to access that? So we don't think through what people have to do and what the cost it is for them to actually get there. That's not monetary. So you think about somebody getting PrEP, or pre-exposure prophylaxis, for HIV, or getting an HIV test because they're actually living with HIV and don't know it, or they know they have HIV, but they need medications. They're late 45 minutes to an hour to 2 hours, and the clinic is not going to see them. So now they're not getting the intervention that works. And there are many other, aspects of care that influences. That's just one specific example. But, I want to work with people to kind of innovate the lens of how we look at healthcare and providing healthcare to people, that's based on cultural preferences, not the system preferences. And that's how we can start to end the epidemic. That's how we can start to improve health outcomes. So, my work is hope, healthy outcomes for people everywhere. And I work with my mentor and a great team from UCSF to get this work out into the community and talk with people like, what do you want to see? How do you want this to look? What would work for you? And my goal is just to reimagine how we provide care to end the epidemic using implementation science, such that we can see all the contextual factors that are influencing our strategies, and make sure that people can move to the center and access care that they need for health.
Yeah, thank you so much. That was such a nice way to just amplify the importance of implementation science approaches. So thank you so much. It really struck me when you were describing someone experiencing homelessness and the challenge of accessing an appointment, that I know a lot of the work you do is centered around community engagement and community partnerships. Can you share a little about advice for people at UCSF who are research teams that might want to engage in successful community partnerships around their work? What would be some of your top tips?
One, I would go for teams, your team. So many times I've seen at UCSF and other places that the team that is focusing on a specific population doesn't have anybody from that population on their team that even understands it, So, just some of the anti-racism work, it'll be a team of white people, women's health, it'll be a team of men. And there's nothing wrong with having men or white people on the teams, but there's nobody to bring in a contextual factor. I realize I have a lot of privileges now in my life, but what I do bring is I've lived in poverty. So I bring that with me in that lens, such that I can be able to see certain nuances that other people may not see. And there are privileges that I don't have that actually I'm grateful for the mentors and the people that I interact with, even with the CTSI, the K scholars. Like they say, oh, just do this. And I'm like, what? Okay. Because I've never experienced that. So having people on your team and building a team that is well-rounded, that has the ability to have a great insight, so great sight, to lens to that population, to understand nuances of the culture and the language and all that's there. You want those people on the team to communicate and possibly even broker relationship with that community. So getting in with the community-based organizations is great. Once you get in there, you can have somebody on your team to broker that relationship. We've built a coalition of many different people. The people on my team, the mentees, interns, co-investigators, all have a range of experiences. I think that's important. I think accessing the centers at UCSF, like the CTSI, CAPS, the CFAR, everybody's great. If you're doing health equity work in whatever area, arena that you're working in, you have people here at UCSF that are on that mission too. So don't feel like you have to do it alone. And in health equity, I do want to add, it is tough. It's a tough journey. You are actually working to shift an entire paradigm. Health equity is, yeah, it can be a buzzword, but it involves, if you're really doing the work, it involves something. And it's not necessarily easy. It sounds good, but changing policy, changing a structure that is based on a reward system, of a financial reward system, is incredibly daunting work if you really want to get it done. So I think that, and then, the funding is out there. The funding is out there. So build a team, have a lens, that understands the structural determinants of health and racism intersect. And now we're getting, I see ageism starting to intersect. We have the baby boomers coming up. So there's this little shift that's kind of bringing that into the game. And of course, like sexism, all of these things kind of intersect for the human being that is at the effect of the interventions that we're trying to get into the community. So just having that understanding, building those teams, I think is really important.
Thank you so much. I know that health equity is really central to the work that you're doing. Can you share a little bit about your advice for people who want to pursue health equity work at UCSF, or what that landscape looks like in your experience doing health equity work here?
I think at UCSF, the biggest thing is getting involved with some of the centers, CTSI, CAPS, CFAR. Those are the ones I know. There are probably way other ones at UCSF, and that's for resources and support. Like we're well supported at UCSF for the research. I think UCSF could actually do a better job financially at supporting the researchers doing community work. For example, I have a $2 million grant to provide mental health and substance use disorder treatment to the community. And, a lot of that money goes towards salaries. And then the indirects are about 180,000 a year. And then our community, because we had to, and we've negotiated and dropped efforts and done all kinds of stuff, the community is getting about 19,000 of it, 19 to 30,000 with participant, some incentives that we have. But, if we part of what we had to do is we were required to buy insurances and things from UCSF we couldn't shop around. We have to go through a specific system. And because of that, that took away from the community. And so if there could be some way that part of those indirects can go to our overhead for the work we're doing, such that we can bring more money to the community, that would help. I think just, or even if it were just some type of incentive to do work in the community, because my goal is to bring UCSF, down from the ivory tower into the community and be a community partner, to show that we do care, because I do believe that there are people that do care. And we need to improve that trust. And so far, we do have trust in the community, and that's important for the health equity piece. So as you're working with marginalized communities, really focus on building the trust. And our work said you need to have a presence that shows that you care prior to any research that you do. So the past 2 years, 2 years, I've been doing a lot of community engagement. Sure, I go out and test people, but I'm just having conversations. I'm asking people what they want. What does that look like? Part of the health, got the population health and health equity scholarship and a Hellman award. These are looking at what do people view as health? What does that look like in mobile clinics? Like, what does it look like as you're working with the community? How do you have to adapt your strategy to be in this community versus being in this community? So really pulling together people such that we can improve healthcare overall. Because you can't just have one structure and say, okay, this is what you get. Congratulations. No, people say that doesn't work for me. I may want like maybe acupuncture. I just more identify with that. Some people identify maybe with plant medicine, more natural holistic healings, but insurance doesn't cover those things. So many times. So, being able to work with people and their preferences such that they can get that. In the African American population, people are not keen on therapy, sitting on a couch and talking for an hour. But you have a cookout or you have a group cooking class or a painting class, that creates health, mental health for people. So, but how are we going to identify that if we don't go out into the community and ask them, like, what does that look like? What we do as researchers sometimes is we say, okay, I have this intervention. I'm going to take it to people and I'm going to say, what do you think about this intervention? And they're like, it works. Okay. But if you bring people to the table and say, we want to create something that people will use, what would that look like? And then you can get the information that you need to develop something that will actually be acceptable and adopted by a community.
Is there anything that I didn't mention that you'd like to talk about?
Yeah, I'm going to add too. I know I brought in a lot of things, but there is, I think people, when you're doing this work, understanding you have bias and being okay with that, like not brushing it off, but just knowing like this is the biases I have, and I need to watch out for them. I've been called on, like I said, one time I grew up in a normal house, and one of my colleagues said, "What does that mean?" And in my bias, a normal house meant like we had a yard and we had rooms, and we even had a garage, like a basement. So it's something I know. And so I can watch out for it in my languaging, in my research. And then also acknowledging that there are cultural affinities that people have, and we may need to bring that into healthcare as well.
Thank you so much, Natalie. It was wonderful to hear about your work and really inspiring to hear about your approach and your wisdom on that. And I'm so grateful for you taking your time. You have so many commitments and things on your plate. So I just so appreciate your time with us.
And I'm
And
grateful for you.
I'm excited for other people across UCSF and beyond to learn from the work that you're doing. So thank you so much.
Yeah, you're welcome.